So the people that are up here are the best of all of you. These are all your peers. They're awesome. They're even getting their picture taken. So the first thing we're going to do is we're going to have each of the panel members introduce themselves. Just tell you who they are, where they're from, and then we're going to do some reflection on what's happened this afternoon and for the last day and a half. And it's going to kind of wrap up what happened in the small groups, and then we're going to have just some closing remarks. So Brenda, why don't you start, and we'll just go down the row and everyone can introduce themselves.
Good afternoon. My name is Brenda Goldstein. I'm with Lifelong Medical Care. We're a federally qualified health center with clinics in Oakland, Berkeley, and West Contra Costa County.
Great. Thanks, Brenda.
Hello, my name is Khatera Aslami Tamplin. I am the Consumer Empowerment Manager for Alameda County Behavioral Health Care Services and a board member for the California Association of Mental Health peer-run organization and a Pool of Consumer Champion member in Alameda County. Thank you.
Thank you, Khatera. Greg?
And I'm Greg Buchert. I'm the CEO for California Health and Wellness, the newest of the Medicaid managed care plans. And so we have 19 counties. I might pepper remarks from my CalOptima days. I was with CalOptima in Orange County for 17 years, and I lived in San Mateo for 2 years.
And Greg is a pediatrician by training.
I'm Sonja Bjork, and I'm with Partnership Health Plan of California. I'm the Director of Policy and Program Development. I live in Berkeley, not San Mateo.
Thanks, Sonja.
Hi, I'm Madelyn Schlaepfer. I'm the Behavioral Health Director in Stanislaus County.
And Madelyn is incredibly well prepared for this panel. I just want you all to know. I'm sure all the panelists are, but
no
I saw
pressure.
Madelyn's notes. She is ready. Go ahead, Eva. You are too, I'm sure.
I've been writing notes about it.
Let's see, I think, is your mic on?
No, I don't think so.
Okay, turn your mic on. Here,
How do you do it?
you push that little button up.
Okay.
Okay, hello, hello. Now try. It's on.
Okay. I think you have to hit it first.
That's a new technique.
I'm Eva McCraven, and I'm the president and CEO of Hillview Mental Health Center Incorporated in the Northeast San Fernando Valley, Los Angeles County.
Great. Okay, so unlike the panel this morning in our living room, this group of living room guests got a set of questions in advance. I'm not going to ask them all the questions because I don't want to put all of you to sleep, and I know everyone is ready to wrap up. And I'm going to start with a question that wasn't on their list. But I'd love for each one of you, and Khatera, maybe you could start, to share, like, what's your biggest takeaway today? What made you the happiest? What did you learn? What made you think the most? So what's one thing that you went, aha?
For me, well, definitely these times are very complicated and very confusing for all of us involved, and obviously that trickles down to the consumers that are the beneficiaries that are receiving the services. But my aha came from our previous group and the work we did in a group and the diversity of the group and how being included in that as a consumer, as a family member, as someone that maybe typically we haven't included, how that for me was so beneficial, and I felt included and to be able to participate and share ideas. And for that, I think we came up with a lot of, I heard a lot of great ideas and also added on to like, oh, let me add this too. And so I came in with like, oh my God, this is overwhelming, and how does anyone hold all this information, to leaving with a lot of hope at the end because of that. I think Dr. Gilbert talked about it, that personal contact is really important. And we know that when we're included and we all work as a team, that people can move through any kind of challenges. And that was really my takeaway is how do we continue working as a team and bring in our experts, our local experts and our state experts together to think of this times and together.
Great. Perfect. Thank you. Brenda, how about you? Turn it on.
I turned it on. Hit it. Now it's working. I've been really impressed with how much is already happening and being tested in a lot of different localities, and I think really in local areas that we have a lot to learn from. And so for me, it was very energizing to be in a room with so many different types of partners and to feel the really not just good intention, but already hard work that's gone into furthering this agenda. Whereas, 5 years ago, very few people were even talking about this. And we're doing concrete things, and we're really moving the policy as well as the practice forward in a lot of different arenas. So that's very exciting, and it's re-energized me as well.
Great. Eva.
I was so stoked by this whole conversation because I feel that many knowledgeable and astute people have been working hard and thinking who really understand the system as it is and understand where the holes are. And everything I think of is from the perspective of having been involved in a community mental health center almost since its inception 50 years ago.
Wow.
And my fear that community mental health might take a back seat is it often has in wrongly having to compete with primary care. So I'm very reassured that we're playing nicely on the state level between mental health and the Department of Health Services, since we used to have a Department of Mental Health Services, and that was gravely concerning. But I feel wonderful from hearing what Toby said, and Dr. Gilbert's conversations made me feel that there's deep understanding that there doesn't have to be one configuration for the integration services that we're about to contemplate, because there are so many levels of need, and he articulated that in a way that touched me, because I feel that there is going to be no wrong door for us. And lastly, there should be no wrong door for our clients and patients. And my last and final fear is that community mental health agencies won't be able to afford to compete in the new system being probably largely managed by for-profit HMOs. Something has to be done to make sure that we can be equal players without losing money for infrastructure costs and all of the things that go along with starting a new system.
Thank you. Sonja.
Thank you. My big takeaway is you are not alone. These issues are so complex. They're really hard to figure out the solution, and there are many solutions, and I'm so impressed with the turnout to this conference on both days, yesterday and today, and the hard work that people really put into the small group breakout sessions, and it was just great to hear so many different ideas being passed around and consider how we could use some of them and what ones might work in our system. So that was my takeaway.
Thank you. Madelyn.
Somewhat like what Sonja just said, I think there's that feeling that we're not alone, that no one has the right answer yet, and that we're all here working together. But I also was so encouraged to hear about the roles that individuals with lived experience can play in this, and the presentations that have brought that up kind of support some of the thinking we're doing in our own county with a much more expanded role for those individuals.
Thank you. Greg.
I'm encouraged by just the fact that here we are in this audience, or you look at this panel, that you do have physical health and behavioral health people together. Hopefully we'll reach that point where it's just health people together. And as I think about the fact that with the Medicaid expansion, you've got many more people who can get coverage that couldn't previously get coverage. Between the with the additional mental health benefits, all of a sudden you don't go from whatever PCP can take care of till you're, wildly impaired, and Medi-Cal not covering that chasm in between. And now you've got 30% of the state's population on Medi-Cal. You've got such a large mass of consumers, clients, patients, whatever you refer to them as, and providers, that there's this critical mass that it's a powerful voice that going forward can be a very potent voice to effect change.
Great. Thank you. Thank you all for those comments. They're very inspiring and reassuring in terms of what work together can be done as we move ahead. So let's talk about, from your small groups and from your own ideas, what's one local strategy that you think could be implemented now that would really improve the system of care for the spectrum of individuals with mild to moderate to severe conditions? What's one local strategy? Eva, great. Go for it.
Communicating with each other. And duh. Well, I know about it from...
It's okay, we liked it.
Communicating with each other was a requirement of the Community Mental Health Center Act. We were supposed to care manage for all of our clients and have team communication within the organization, and we took that very seriously. And so I started trying to organize what we're calling a health neighborhood coalition in the Northeast San Fernando Valley to try to recapture all of that by finding out all of the agencies that our clients interact with for their health, their vision care, their dental health, their housing needs, and their employment needs, and calling a meeting together and exchanging names. We're going to try to make a simple directory and try to have an updated list of people to talk to. And we don't do the kind of case management that we did when we were funded to do it. But we still have to be aware of our clients' health needs particularly. So I've tried to institute that at our agency by having all the doctors communicate with the other clinical staff when people have physical health problems, and doing a one-to-one kind of communication. And so I hope that by doing that, our community might be ready to take advantage of opportunities to set up new electronic communications between us, because it's hard to communicate between mental health and primary care because of the scheduling and the culture, and the doctors who have to see somebody every 15 minutes. How are they going to have a nice little conversation with your psychiatrist? And so we need to have other workers, care managers, maybe nurses, who can talk to each other, pick up the phone. And it's just not rocket science, and it's what we know how to do. So why don't we reformalize it and then look for ways to make it up to the modern age?
Anybody else on the panel? Yeah, go ahead, Brenda. Want to talk about this issue of building relationships, because it's so basic to making things work.
Well, what I was going to say is that I think, while we know that we have to build our IT systems and communication systems, we have to grapple with payment reform and all of that, those are big long-term solutions, and that some of the things that are happening locally that can work right now are to build relationships across organizations and focus on small populations that are at particular risk and need for care management and attention, and that you can have some immediate success and test out your systems of care. And I think that, if we all speak to each other and see where the common ground is around where we're going to get the best result in terms of better outcomes as well as financial outcomes, and proving our case around using resources wisely, that and start small through those kind of local collaborations, that will be paving the way for bigger things and for using our larger systems and applying some of the financial reforms in the future.
Brenda, give a couple of examples of those small groups of clients that might
Sure.
fit into this approach that you're talking about, just so everybody's clear.
Sure. So, I
About
mean,
your
I forgot
idea.
to say that one of my takeaways is that I'm planning to move to San Mateo.
Well, Louise Rogers is
Except
here,
the
and she'd be
commute
happy
is
to
really
talk to you.
bad to Alameda County. But Louise was talking about
Louise will drive you.
subpopulation and focusing on, say, some of the substance use folks with substance use. I would say in Alameda County, we've looked at frequent users and homeless individuals.
Right.
I think that you can look at your data, and that's another piece of it, is to bring together our data so that we can make some wise decisions that are based in at least what we can gather now from outcomes and cost data. And we pretty much know where we can have some impact. There have been lots of pilot projects out there already across the country that we can learn from, and then applying that to those high-risk populations. Also, transition age youth, where you can really do more in the way of identifying folks early on who are having mental health, substance use issues, as well as developing physical health problems. So those are some examples that came up.
Good, thank you. Madelyn, did you want to jump in?
Yeah, I think that, like Molly said this morning, relationships are really key. And in our county, we've had a number of opportunities to build relationships with the healthcare side of our county. And I think as a result of that, I recently brought an idea to them, which I think would be very helpful, and that is that there are these one-year fellowships for primary care physicians or internists to sort of develop their psychiatric skills. And we've tried, and when I first presented it to them, they were excited about that. We're looking at using some of our, the potential of proposing to use some of our workforce education and training funding, but they jumped in and said, hey, we've got ideas and we think this would be a great idea. So I'm proposing that.
Wow, that's great. Sonja?
Regarding relationship building, I look around the room and I have so much gratitude for all the partners that we have in the counties that our health plan works in. Right now we have 14 counties that we're serving, and the openness of different stakeholders in each of those areas to be willing to meet, to attend meetings, to be on webinars, it's just been fantastic. And this has been a really complicated benefit to get up and running, and yet people have been willing to, puzzle through things. And I'm talking about specifically the county mental health directors were so patient and gave their time in developing the screening tool that we decided to use. That took hours. I mean, we had several meetings to puzzle through that and get everybody's agreement, and it was a really good process. Then there's other types of relationship building that have happened by invitation. And I got asked to go to the NAMI meetings in Yolo County and in Solano County. And what a great opportunity that was to talk to parents, friends, clients about how this new system will affect them. And then we're involved in many local groups, like Napa is here today, and they have health policy work groups, and they donated some of their agenda time to talk about this new benefit and how it's going to work. And then we've had big stakeholder meetings in the north, like in Reading, so we had a chance to talk to our partners up there. And all of these opportunities, I feel, have just really helped move things along. There's so many confusing parts of how this is going to work, and there's a lot of different levels of understanding of how things are going to work. And when we're all talking, we can try to get on the same page. If we weren't having these opportunities and taking advantage of chances to communicate, I think there would be even more frustration out there and a lot less trust between the parties. When you're talking about screening and people are really worried that their clients are going to get screened somewhere else and sent here or there, that's not just a hypothetical. That's, I'm worried about my clients. And so I just feel a lot of gratitude for people, their willingness to engage in this with us. So thanks.
Greg?
I think one thing that we can do locally is take a more proactive as opposed to reactive approach. We often look at the system when it falls apart or it fails somebody, but what can we do in anticipation? And one thing that I know that we do on the health plan side is every one of our new members has an initial health assessment. We reach out to, all 130,000 of our members, make calls out to them, if we've got good information from the state and all those other caveats that you're all painfully familiar with. But, I see changing our tool a couple ways to adding a couple questions to really get some targeted questions that might identify those individuals that then we can bring in our behavioral health colleagues and try to identify people earlier than we would have and get them into the system and make sure that all those dots get connected, such as if they actually need help, that we provide transportation and things such as that. So start from identifying people at the earliest possible stage that we can.
Greg, maybe just for everybody that's here, explain what the requirement on the health plans is for the initial assessment, so everybody's aware of when that happens and what you're required to do.
So there's a number of questions that we are required to ask of our new members to try to identify patients that have high-risk conditions, both, right now it's marginal in terms of the behavioral health, probably more on the physical health side, and that those that reach a certain level then have to go to a second level of screening that is a much more intensive screening, identify people for case management and, improved care coordination. And those are the people that we want to reach out to and make sure that they are connected with the system. And also how to use this incredibly complex, often fragmented healthcare delivery system.
Thank you. Khatera, what's one local strategy that you think would best serve the system?
Develop and use a peer beneficiary controlled personal health records, and that promote self-determination and improved care. So how do we empower the consumer to have more control over their personal health records and so since our system is currently fragmented and we bounce between, one agency and another, we can empower the individual to have control over that information and their own, their records and share it with whatever new provider they go to. And also, in addition to that, there would be a peer navigator that would help educate them about the use of that and then support them in the, kind of navigating the whole system that follows the individual, not the programs. It's focused on, being there with the client, engaging them and connecting them to resources, and who better to use than people that have been through the system and know it and can offer support and hope.
Would you describe just a little bit how the individualized record can be created and how you advise the client to use it?
Well, I think it would need to be created collaboratively with the partners. I think not one group has all the answers, so I would hope that that's the way we approach this. But in the education piece, the peer navigator would have information about it and could spend more time with the beneficiary in understanding it and being able to try it out and see if there's any, challenges. We know that the workforce is, really stretched thin and time is not always, people aren't always available, but we have a workforce, especially in Alameda County, we have 800 members that are part of the pool of consumer champions that have been active in their recovery and in helping transform the system, that are just waiting for these opportunities to help the system out and connect other people to, what our goals are, is access, improved health outcomes, and satisfaction with services. So I think that the peer navigators can really spend the quality time with individuals that we're trying to help.
Brenda, given that you're also in Alameda County and your organization as an FQHC is primarily a medical provider, the bulk of the services that are provided, have you all used peer navigators to assist your clients?
We currently have a CMS Innovations grant where we're using peer navigators who are linked with the Center for Independent Living with a focus on folks who have either physical or behavioral health disabilities. And it's been a really interesting process for us, not easy for sure, because we're working with another community-based organization that has a very different culture and that's been very hesitant about becoming medicalized and working with a medical institution. But we're finding tremendous results from integrating the peers into our primary care system. And I think most primary care providers don't have the history of using peers that mental health and substance use programs have. We need to learn how to do it. Although we do use a lot of community health workers who may not have the official professional title of peer attached to it, but who come from lived experience and who don't necessarily themselves want to identify in the workplace as a peer per se, but they bring tremendous skill and knowledge of the community and ability to relate to our patients. And we've particularly had a lot of experience doing that in our supportive housing program, but we also have been doing that in primary care as well. So I think it's something that we need to learn more about, we need to have more support, and we need to figure out how to pay for it.
So Greg and Sonja, from the health plan perspective, any thoughts about how the health plan can encourage the use of peer navigators and the personal client record?
I agree with you. It's actually, I think it's a fairly rare concept that the physical health providers even know about peer navigators. And I think, quite frankly, a lot of the physicians, and I'll say it as one, but there's a lot of skepticism about case management and care coordination overall. That, as we're trained to be fiercely independent, that we own the patient and have ultimate responsibility, to cede that responsibility to somebody else is often a challenge to the healthcare providers, the physicians, the nurse practitioners, the PAs. But I'd say the number one thing is that we have to actually make them available. And we've got a member connections program where we have promotores that are working in the community, and it's actually expanding their scope of responsibilities and also hiring people that could be peer navigators. And so it's not a matter of well, you take care of the physical health and we fragment it still, and you take care of the people with substance use problems or issues like that. And so it's actually hiring the right people, establishing expectation, have a broad enough program, and also being able to demonstrate results. And so I think there's that whole evaluation phase that brings in, to hopefully validate that and make it a standing practice and expectation for the providers in our networks.
Thank you. Brenda wants to add something.
I just wanted to add something really quickly to that, which is that as we're developing health teams and learning to be more efficient at the primary care setting, we're needing to really look at how our non-licensed folks are interacting with our patients and carrying the agenda of working with folks around managing their health conditions. And one of the things that I think is challenging is to help really get people trained up and with the skills around brief intervention and behavioral activation, those types of skills that can be used, and that's something that maybe as communities we can really create resources for that kind of training and support. I think it's difficult for us as individual agencies to do that and really maintain it.
And some of those resources are already available, so when we come together, we're able to share that information.
Thank you both. Sonja, anything to add from the health plan perspective?
Yes, at Partnership, we're real big into pilot projects and trying.
Don't tell the boss.
Yeah, trying different experiments. And a couple of the pilots that we're doing right now are focused on care coordination and health home initiatives. And some of the recipients of the grant funding for that or the participants have experimented with using peer navigators. And it's going to be really interesting to see how the results come in. Also, as a health plan, you have to think of what different roles you can play, and one of the ones that we try to play is a convener. And so we often will hold trainings that we invite people in our network to come to. So, for example, recently we had a patient activation training session that people could come to and send their staff so that they would get the skills. You know, you can do 2-hour trainings or you can do 3-day trainings on those. And so providing the opportunity for people to come who might not have the resources to pay for that at their own clinic. And so we're trying to do more of that, where we can be the convener of a certain topic and provide expertise and training and let people walk away with a certificate or things like that. So I think that is one of the good roles that health plans can do, particularly when you're in a lot of different counties. Everything turns out to be local anyway. So if you're serving different counties, to take a look as a health plan, what's needed in this area and what can we provide.
Thank you. So I want to shift the topic. I was a little surprised this morning when I asked my dear friend, Dr. Brad Gilbert, about what the health plan's role is in helping local medical providers deal with stigma reduction that exists among the providers and exists among their staff. And how are we thinking about educating those providers and their staffs about issues related to mental illness and addiction? And I'm wondering what ideas you all have, and even Madelyn, why don't we start with you, about how the safety net can work together to reduce stigma among the provider community and the staffs that work in provider organizations.
I came up in our am I on? In our coalition meeting because I think people are quite well aware that the idea of some of our seriously mentally ill clients wandering around in primary clinics is daunting for the professionals there. And our coalition is talking about maybe joining up with others to try to find training dollars and put together a curriculum that would be not complicated and probably approaching NAMI, because they've done pioneering work on the subject of stigma, and maybe we can collectively gather training materials and start with sending brochures and enlightenment kinds of pieces to make people stop and think that maybe they're afraid of the mentally ill because they don't understand what to do about encounters.
Thank you.
Yeah, I think this is an issue that we've confronted much more with a number of our folks ending up in ERs. And, you know, there's this comments being made that I'm sure they hear that are very disparaging. So it has been a challenge. I think there are a couple of things. One is that when our staff hear those comments, they need to say something. That's stigma. And we also need to help our consumers actually stand up for themselves as well. We're having quite a bit of luck with that with our younger group, and as they step into leadership roles, they really aren't tolerating that. They also, we present, we do the kind of NAMI presentations in our own voice, which is very helpful. Unfortunately, I don't know that we reach the ERs where they have trouble handling the situations there anyway, and so they don't have much time for training. But I think that is an area we really need to focus on.
I'm so glad you brought up the issue of ERs, because I hear it all the time. Whenever you talk to hospital administrators, the first thing they want to know is, how can I get these people out of my ER as fast as possible? And it's always these people, and you know immediately who they're talking about.
And they're saying this in front of, I mean, I can't imagine being in an ER where you're hearing someone out in the hall say those kinds of things.
No, thank you. Sonja and Greg, any thoughts in terms of your provider network and how you can help the providers and their staffs in this area?
One interesting thing is that a lot of times the state or health plans are telling providers or telling them how to be or how to do things. And so I feel really strongly that health plans have to look at their own staff and their own way of meeting with people and how you treat them before you go out and tell other folks, these are our expectations of how you're going to work with members. And so we do have some training for new employees, and also even everyone at the health plan goes to them about working with our members who have disabilities. And it always, people, it's hard to get time on your calendar. I don't want to go to this meeting. I have a report due, or I have so much to go on. And then every time when the training's over, everyone's so happy that they went to it, and they just have a greater empathy for the folks or the family members that they're talking to on the phone. So I think health plans have to look at their selves first.
Perfect. That's wonderful.
I think it's actually a multi-part strategy. One is, I think we bring the stigma on ourselves. The fact that we have separate payment streams for physical health versus behavioral health. The fact that we say we can't communicate between physical health providers and behavioral health providers. And, the fact that, that we still make that distinction is number one. If we could eliminate those things, all of a sudden it makes them like anybody with congestive heart failure, asthma, diabetes, or or a runny nose. It's just they've got a health issue that we need to deal with. I agree with the issue about the training of staff, and it's interesting because we do have requirements to train staff about and increase sensitivity about persons with disabilities, but with the mental health benefit being carved out until January, I suspect that anybody who's done that training hasn't talked about dealing with persons with mental illness. And so that training issue is the second one. Third one is that we need to be employers of persons with behavioral health conditions, and we need to make accommodations for them just like we would for somebody with a wheelchair or blind or something like that. I think we could also be training our families to be better advocates and work with them to help them be stronger and advocate for them. And finally, go back to one of the statements this morning about whenever there's some mass murder or somebody in a movie, they've got a behavioral health issue. Why don't we have some good role models in the movies that have behavioral health issues that aren't evil people? Here we are as a state paying hundreds of millions of dollars to support a media industry. Why don't we put a few tags to that money to say we need some healthy people that, oh, by the way, they're depressed, or by the way, they've got schizophrenia, or make them characters that we actually like and can embrace and actually relate to.
Thanks, Greg. Brenda, as a provider, what advice do you have about helping overcome issues of stigma among provider staff and support staff who work with providers?
I think that integrating behavioral health and primary care and normalizing that these are all parts of who we are and what we do, and is really the best way over time. And it's interesting, we have a newly renovated building in West Berkeley, and we have a psychiatrist who's full-time and a full-time psychiatric nurse practitioner embedded in the primary care teams there. And our psychiatrist's office, he has his own office, and it just says psychiatrist on the door. And several visitors have come there and said, well, why do you have psychiatrist on the door? Everybody will know that they're seeing a psychiatrist. And our patients have no problem, and it's very normalizing. It's just psychiatry is part of healthcare. It's part of what we offer. And the psychiatrist says, it's great. He says, I'll walk through the waiting room, and everybody says hello to me. They're not embarrassed that they're seeing me. And sometimes it's our own attitude that we're bringing to it that actually, I think, then gets conveyed to patients that you should think there's something wrong with you because you're coming in for this mental health treatment. And we need to be open and normal and relaxed and be talking to each other, and I think that's what really will normalize things. The other thing that I think is really helpful is giving staff really positive feedback when care is going well in an integrated model, and when we're having good outcomes with our folks who have serious mental illness, and with folks who may have been difficult in the past. And I was really excited. About a month ago, we got an email from somebody from our county mobile crisis unit thanking one of our clinics for how they had handled a situation with with a patient who had serious mental illness and was having a difficult time in our waiting room. And that went a huge way. I mean, everybody in the clinic got the email. Everybody knows that we're working with a wide variety of patients. And it was really reinforcing about not just this is the right way to be treating our patients, but you have the skills, you have the empathy, and we appreciate that. And I think that kind of positive communication and feedback about the good work we do is really important, because we hear a lot of the negative stuff, but we are doing a lot of good work already, and reinforcing that is going to go a long way.
Great. So I'm going to ask one last question. Oh, Khatera, sorry. Please answer the question on stigma.
Answer that?
Yeah, sorry.
It's one of my favorite questions. Earlier today, Dr. Gilbert made a statement about he's a huge believer in personal contact, and I said that earlier again. And in the consumer community, as a person with, been diagnosed with several diagnoses from bipolar depression, post-traumatic stress disorder, we agree. We agree that personal contact, and so also the number one method that's been researched by Dr. Pat Corrigan, that's the expert in this subject, is targeted, local, credible, continuous contact. And so the first step as we're talking about this is this right here. This is, first, including consumers and family members at that table, the agencies, consumer-run agencies, the local ones. There's a lot of local consumer-run agencies throughout the state of California that are doing work within the community, and I think a lot of us would learn a lot from each one of them. And then the statewide consumer-run, agency that is the voice for consumers, that has, is in touch with what's going on as we're integrating care. How are people experiencing their care in primary care settings? And we always, we've worked hard to get at the table with behavioral health, and this is critical as we're integrating, to be at that table also with integration. So one of the first things I want to do is ask everybody in your counties, when you're talking about integration, do you have a consumer at your table? Do you have a family member at your table? That's the first assessment we have to do, because if we can do it at that level, then we are able to learn about what's going on throughout our system of care. And in Alameda County, we have contracted through MHSA with one of our consumer-run organizations, peers, to run our social inclusion campaign. And this year, with Pat Corrigan's method, they're targeting primary care providers, FQHCs. So coming up July, we'll be focused on building relationships with primary care providers, and it's local, and they have continuous contact with consumers that are going to share their story of recovery, and how we see change, long-lasting changes through that continuous contact. And I want to plug that Cal Mesa has done an excellent job at providing resources for our state around stigma reduction efforts. So I really would recommend going to their website and checking that work out.
Thank you. That was great. So last question. You've each got a magic wand in your hand, and you're in charge of the world. What is the one thing you would tell the state of California? Toby's sitting here, but he's not here, but he was here this morning. What is the one thing you would tell Toby Douglas to do immediately to promote the integration of behavioral health? Who wants to go first? No. Madelyn, how about you? The one thing, the most important thing to you.
Well, they can start pushing health information exchange and data at the state level so we can find out what's working and what doesn't work.
Great. Great start. Okay, Eva.
I really second that because we have been required to submit so much outcome-related data with, by the way, no reimbursement for doing it. It's really taken away from our viability almost in some cases. we need to have that be a formal part of any new system, data collection, evaluation, and outcomes, because I strongly believe we need to know why we're doing what we do. It's not fair to all of the people who are in the system and are so depending on us for us to not really know why we do what we do. But we need help.
Great. Thank you both for that. Brenda, what would you want the state to do differently? The one thing.
Oh, there are so many. It's so hard.
Pick one.
I'd really
Or
like
talk
to see.
fast
I'd
and
really
say
like
two.
to see a viable funding stream for care coordination, case management, and peer support.
Great. Good. Okay, Khatera.
I'm going to say pay for performance incentives, give bonuses to agencies that have higher patient satisfaction scores, and let's make sure that information gets back to the counties, and let's be transparent. Let's evaluate each other on who has high patient satisfaction scores, because I think that will drive improvement.
Fantastic. The two people on the panel who probably have the most contact on a daily basis with the state are Greg and Sonja. The health plans are talking to the state multiple times a day. So what are you going to tell Toby tomorrow when you talk to him?
I like all the suggestions that have already been made. I would like a really strong policy that supports a true no wrong door for the consumer in this situation. I'm concerned that everybody's worried if they see this patient and it turns out they really were SMI, are they going to get paid? Or if they see this patient and it turns out they weren't, are they going to get paid? And I just think it would take the weight of the world off of providers and any stress off of consumers if they could just get served, and if everybody showed good faith efforts, that their payment would not be in danger, and we can all relax and provide the services.
Fantastic.
Bobbie knows I'll come out with something outrageous, so I will.
Good.
I would ask him to consolidate all healthcare funding streams to go to a single entity, and it could be multiple entities, but have one entity that's held accountable for the entire care of an individual, to eliminate all the administrative duplication and have a single case manager to coordinate all the services. And in return, they have to, that entity, health plan, medical group, clinic, whatever it is, has to document continuous improvement in the person's health care.
Awesome. Well, this living room has been filled with some amazing insights and perspectives. I just want to thank all 6 of you. It was wonderful, and they represent all of you, so thank all of you. Great session.